We have Dr. Margaret Paulson, who has over a decade of experience in providing care across the spectrum of internal medicine, including outpatient and inpatient settings, nursing home, and correctional medicine. After completing her residency and chief residency in Arizona, she returned to the Midwest, where she currently practices hospital internal medicine at the Mayo Clinic Health System in Northwest Wisconsin. In 2019, she became the chief clinical officer for Northwest Wisconsin in the exciting establishment of the Mayo Clinic's Advanced Care at Home program, an innovative platform offering acute hospital-level care in the home. The launch of the ACH allowed Dr. Paulson to call upon her experience in both outpatient and inpatient internal medicine and to expand high-quality telemedicine in transformational ways for Mayo Clinic. When she's not working, you can find her trying to keep up with her 3 kids, running or skiing, depending on the weather, and in search of delicious gluten-free baked goods. We also have AJ Dunn, an administrator for the Mayo Clinic Hospital in Jacksonville, Florida, where I believe I met him when I interviewed. Mr. Dunn partners with the hospital's medical director to provide oversight of operations with a focus on clinical outcomes, patient safety, consumer experience, and affordability of care. Mr. Dunn joined the staff of Mayo Clinic in 2002 after completing a bachelor's degree in physical therapy and a master's degree in healthcare administration at the University of Florida. He holds the academic rank of Assistant Professor of Healthcare Systems Engineering, Mayo Clinic College of Medical and Science. Passionate about education, leadership development, and civic engagement, Mr. Dunn has deep roots in local, regional, and national nonprofit service. He serves on the board of the Nonprofit Center of Northeast Florida, the Community Advisory Board for the University of North Florida's Health Administration Program, and as a regent for the American College of Healthcare Executives. So we hope that this presentation will inspire our participants. And without further ado, I open the floor to their presentation. Please let me know if you have any tech troubles.
Okay, thanks, Morgan, for that kind welcome. So I just want to make sure you guys can see the screen. Does that look good? All right. So AJ and I are here today to talk about our baby, our hospital at home program, and how home is the new hospital. So when we talk about the hospital at home concept, a lot of people ask us like, well, what are you doing? Are you going back in time? And that's a little bit of what we're doing. So the original home hospital was at home, or the original hospital was in people's home. So up at the top is a very famous painting called The Doctor, Sir Lucas Fields. And yeah, so when we think about home hospital, we think about the doctor bag going out. And I guess I started wondering, when did this change? When did we go from home hospitalization to institutionalizing our sick people? So I don't know if we have anybody from Philadelphia, but the first hospital in the United States was in Philadelphia. It was Pennsylvania Hospital in 1751. So Mr. Tom Bond was a gentleman who grew up in Maryland. He went over to London to get his medical training, where he became a physician. And part of his time he spent over in Paris. And he was just blown away at how efficient it was to take care of patients when you have them all in the same space. You could basically go from area to area to area. Back then it was just one big ward, but it was very efficient. So when he came back to Philadelphia, it was the third largest city in the colonies at that time. He got to talking with his friend Ben Franklin, and they noticed all of these people out in the streets. Sick people were dying, and they got together to form the first hospital in what would be the United States. And they did this, as written here, to care for the sick, poor, and insane who are wandering the streets of Philadelphia. So they really had a strong why for forming their first hospital. So when did that change? So if you fast forward now to 2021, we have over 6,000 hospitals according to the American Hospital Association. Over 900,000 hospital beds with 36 million admissions annually, and at quite a cost, over $1 trillion. So you might wonder, okay, if things are going so well, why would we return to this hospital at home concept? So if you've ever been a patient or had a family member been in the hospital or had the privilege of caring for somebody in the hospital, you would understand why. And these are just a few of the things that I hear from my patients. So, especially now with COVID, we haven't had visitors for the longest time. So families and patients have been really upset about that. Hospital food isn't noteworthy for being exceptional. So a lot of people have complaints about the food. And here in Northwest Wisconsin, we have a large Hmong population. That's a big problem for them. They come in the hospital and they don't have any of their food that they would normally eat. So it just feels really foreign already in a very scary situation. Patients are tethered to their bed. We put them in there, we put bed alarms on them, chair alarms on them. They feel like they're in prison. A lot of people get really confused. They come into the hospital, they don't know what's happening, and they're sleeping in a terrible bed. So lots of reasons why we might want to consider going back to the home hospital. This was also a really provocative piece written by a couple of my colleagues in Arizona, Drs. Mishark and Geyer, and raised a lot of questions when they wrote how hospital stays resemble enhanced interrogation. So they took the CIA interrogation manual and they kind of compared it to how we take care of patients. So, we bring them into the hospital, we strip them down, we give them a uniform. Oftentimes they don't know day from night. We turn on the lights at really strange times. We violate their privacy. And it's no wonder, right, that the hospital can be this really scary, awful place for a lot of our patients. So besides the patient experience, what are some other problems with hospitalization? Why would we consider an alternative model? Well, one being unintended clinical adverse events. Certainly access to care is a problem, as well as cost. So when we talk about, treating our patients, we go in, we try to do our best, right? So somebody comes in with a heart failure exacerbation and, I'm like, okay, well, I'm here to make you better. But they come in and this patient gets delirious, just like 20% of our patients in the hospital. They're in this really unusual environment. Day and night is flipped around. So 20% of people get delirious. As I mentioned before, we bring people in the hospital, we put them in their bed, we put on bed alarms because they're a fall risk, or if they go to their chair, they have chair alarms. Maybe they have somebody come in and actually watch them. So it's no wonder that patients get weak and deconditioned when they're in the hospital. Also, that same heart failure patient that I brought in, I'm taking the water off, the fluid off, diuresing away. And unfortunately, that patient ends up with C. diff infection. So hospital-acquired infections are also a really big problem. So how can we do better? This is an easy slide to talk about with capacity and ER wait times, especially in the time of COVID. So here in Northwest Wisconsin, last fall, we had a Washington Post reporter come, and that's what this picture on the left shows. And that's actually one of our community paramedics, Adam Glass, who I saw in the room earlier today. So really they came in, and the question they ask is, inside a hospital as corona surges, where will all the patients go? And we were so proud because even though our hospitals were full, we were able to offer our patients a bed with our advanced care at home hospital program. So it was really exciting. And yeah, other pieces there, Minnesota certainly did not escape the problems of COVID. Florida got crushed. Arizona was crushed too. So it's a problem, right? Like, where do we put all these people?
So, based on what Dr. Paulson's described thus far, we're not doing so well, right? So we've got issues as we think about the patient experience, the outcomes, the access, the equity of healthcare. And then we also look at the cost. Taking a step back as we think about the economics of healthcare in this country, gross domestic product has gone from at 1.12% of healthcare spending as a function of gross domestic product has gone from 12%, 16%. We're now approaching 18%. And it's been estimated by a number of economists that if we cross the 20% threshold, essentially healthcare becomes disruptive in terms of being able to fund the other parts of the government. And so for the cost of a 3-day stay, on average, the cost of hospitalization is $30,000. And as we look at bankruptcies tied to medical expenditures, that's over 2/3 of those bankruptcies. So if we look at the next slide, what that all does is it takes us to advanced care at home, which for me is an interesting place, because as a self-respecting hospital administrator, it starts with the fact that there's things that we could do better. Yes, we offer hope and healing in amazing ways to patients, but we could be so much better. And so this is really an attempt at Mayo Clinic to say, even though if you look at the external rankings, the care delivered within our walls is at times ranked at the best as one could get across the globe, the care within Mayo Clinic, but we can't rest on our laurels. We have to continue to figure out ways to progress. And so advanced care at home is us putting a stake in the ground saying, we will figure out ways to disrupt ourselves using advanced technology, logistics, and a whole array of new clinical ingenuity. So if we move to the next slide, what you see is the opportunity for us to really rethink the patient experience, to give the patient much more comfort, convenience, and control, to reduce the stay in institutional settings or completely eliminate them, to fundamentally shift the economics by reducing the cost of care, by cutting out all of the fixed overhead associated with traditional hospitals, and then to improve the outcomes, getting patients up, getting them moving, and preventing infections. So the challenge really is, as the primary thesis, can we deliver a better experience, better cost, equivalent or better outcomes at a lower cost? And that really is the challenge. That's it. That's all we're trying to do. Fundamentally shift how medicine's been practiced for all of Western history. Next slide. So one of the things we've tried to do is to take a platform-based strategy as informed by Dr. Firouzja or Board of Trustees or Board of Governors, trying to think about really fundamentally using technology. And so what this allows us to do is really closely collaborate with partners across the entire enterprise and with external partners as well, such that we have communities where we're able to deliver care tethered to a command center. Today, the command center is in Jacksonville, Florida, and we have supplier networks that are up and running, delivering care in Northwest Wisconsin and in Jacksonville, Florida. So essentially a 20-hour drive away, care is being orchestrated in 2 communities, which can quickly expand to 4, 6, and really a limitless number of communities where centralized care can be delivered in local communities. And we'll walk through a little bit of the logistics in the next slide. So we talked about the command center as really the focal point for the spaces that we deliver care. And here's really, I think, a bit of a busy slide, but one that really, I think, helps you to think about how this model works. In the center is the patient in their home, eating their food, in their clothes, in their comfort zone. And we bring to them a technology stack. We'll show that later, but a technology stack that gives the ability for providers to be able to have second by second a sense of the biometric status of patients, to be able to communicate with them via iPads, via phone, to create the infrastructure to be able to care for patients. Connecting that to that set of technology is a software platform that transmits all of that information in a really seamless manner. That goes to a command center of providers who are able to make clinical decisions around the care of the patients. And then ultimately, there's a supplier network that's the ring surrounding the central picture, where we're able to go into the home to do mobile diagnostics, community paramedic services, lab, radiology, pharmacy, wound management, all of the services that one might need in a traditional inpatient medical stay that's non-invasive, we're able to mobilize and get to the home to deliver just-in-time care. The technology stack is shown on the next slide. So this just gives you a quick sense of some of the technology that's in the home. So again, you've got the opportunity to have a whole array of devices to give the patient a sense of comfort that we know exactly how the patient is doing. We have a number of communication devices. We also include things like building an own dedicated internet connection so that if the patient's internet goes out, we're able to have some redundancies. We have a dedicated backup power. So if the patient's power goes out, again, we have dedicated power. So we really are taking the home, taking someone's living room, for instance, and upfitting it and creating the capacity to be able to function as a true hospital room. Next slide. So some of the limitations. What we're describing today is incredibly innovative work that we're doing with an external partner, Medically Home, led by Drs. Mariachi and Paulson across the enterprise. The challenging part is that there isn't, in today's world, a reimbursement model for the delivery of complex hospital-level care in the patient's home. We have to really understand the patient's clinical stability and social stability so that we know that we can pick the right patients. There's differences in how we might deliver this in an urban setting versus a more rural setting. And so though we have put together what I think is an incredibly ambitious, disruptive, and patient-centered model, it's not without challenges that we're navigating in today's landscape. Next slide, please.
So a little bit, we designed this as kind of a minimally viable product, and we have a long way to go, especially I think Mayo's done a great job of shining the light on the opportunities we have to make our care more just, more equitable, and how we can bring diversity and keep diversity top of mind. So with the product that we have right now, you know, if you don't have a home, that's a problem. So how do we bring hospital at home care to you if you're homeless? And certainly you need the technology, you need electricity, you need cellular service or wireless internet. So that becomes harder if you're lower socioeconomic status, vulnerable, marginalized. Secondly, if you don't speak English, this platform also doesn't work for you. So right now, you know, we're talking over the video and we don't have video interpreters as part of our advanced care at home platform. So that's something that we've been thinking a lot about, how we can make this care platform available to people who don't speak English. And also people with disabilities. How can we bring this model of care to people with disabilities? So that's something that we're dedicated to improve upon. So, oh, there we go. So we launched our program in July of 2020. And through December, we took care of 102 classic ACH patients, advanced care at home. So heart failure, pneumonia, cellulitis, those types of patients. We took care of an additional 41 COVID patients, which was really exciting. We weren't planning initially on caring for COVID patients, but this model allowed us to pivot. We had built the care network available to go to the patient's home. So we were able to pivot and take care of COVID patients. We took a patient straight from the PACU after his orthopedic surgery. So that was also exciting. And our colleagues in Florida also took care of a large number of, we call them care hotel patients. So patients who would have been ordinarily in the hospital for a night or two, we were able to free up those hospital beds. So that was really exciting. And here what I wanted to do is really show you a patient video, because that has been really powerful. So.
Dr. Paulson, we can't actually hear the video right now if you mute yourself.
Dr. Paulson, your audio might need to be on for us to hear the audio. Otherwise, it's moving.
Okay. I can hear it, so I'm not sure what the scoop is with that, but I can certainly send you guys a link. It's behind the Mayo Clinic firewall, so I'll put that out, but you'll have to be on your VPN to make it work. So I apologize for that. So with that, I guess I just want to thank you guys again. Thanks for having us. We're really excited to be a part of the innovation sprint today, and certainly AJ and I would be happy to take any questions.
For any of our participants, you can either put your questions in the Q&A to the right, or you can let us know through the general chat. While they're compiling some questions, AJ and Dr. Paulson, one question I might have is, could you say perhaps what would be a project that some of the participants could work on today that something creative that might be a benefit that they can throw their efforts on over the next 2 days?
Yeah, I think one of the things that we've struggled with is, and we're excited. You're going to hear from Dr. Chaudhry next. He's been helping us peel the onion on how we can enroll people more quickly, how we can identify patients more quickly, how we can identify the right patients. So that patient acquisition piece has been hard for us. I think another thing would be certainly everything on the diversity, inclusion, equity side, where we think about how do we make this available to people of all kinds who speak different languages, people who have disabilities. So how do we not make this a model for wealthy white people?
A question in the Q&A right now. Are you accessing global risk contracts to fund this awesome innovation?
So one of the things we're doing right now is really reaching out to both tech partners and benefactors to see if there's a way to be able to get funds to access that we can use to invest to move more quickly. We've also been able to tap into some internal Mayo Clinic resources such that we've been able to get some dollars to help us move more quickly. We could be growing this at a 5%, 6%, 7% rate, but we really want to be much more ambitious. So we've been able to tap into a bunch of different funding sources.
Next one, could you comment more on Mayo Clinic's plans on switching patients to home care, the timing, the extent, etc.?
Is that a question about home health? I guess I'm just looking for a little bit of clarification from Martina on that.
Oh, you can read these. You go ahead and then work your way down the list. Good to go.
So one thing I would say is, assuming they mean home hospitalization, what we'd like to do is move from where we are today, which is about, in the sites that we're active, 1% to 2% of our admissions, trying to get somewhere into probably the 10 to 20% of admissions. And that really is a function of us being able to increase the number of payer contracts that we have, increase the number of clinical use cases, and expand our geographic footprint. I'm not sure if Dr. Paulson would want to add.
Yeah, I guess I'm just looking at what Martina wrote. So just to clarify, so our program, Advanced Care at Home, isn't home health. So it's really, we target patients who, like home health is basically when you don't need the hospital. So we don't take those types of patients. We don't take patients who need ICU level of care or need a lot of interventions, surgeries, procedures. We do take patients who need, we call it inpatient level of care. If you're earlier in your career, you're not admitting patients. There's a lot of different patient status determinations for when they come in the hospital. And so we take people who need to be in the hospital at least 2 midnights, and they're sick, right? So they have pneumonia, or they have a skin infection where they need IV antibiotics. So we do offer home health as part of the services after their home hospital stay. So our service is kind of the product that we offer includes the acute hospitalization and then kind of this restorative phase. During that restorative phase, they can get home health. So I hope that helps clarify that. So is it easy to convince the patient that it's safe to be home rather than in the hospital? That's a great question, because you want to make sure that people understand what they're getting into, right? So when we're consenting patients, we have to be very upfront with them about the risks. So when you're at home in your home hospital, it's different if there's an emergency than if you're down the hall in the brick and mortar hospital. So in the brick and mortar hospital, people can come running and they'll be there usually very quickly. In the home hospital, it takes a lot longer. If somebody's crashing, we would activate the 911 system. That's probably going to be one of the quickest ways to get people there. But we try to detect early deterioration by having them on with the biometric equipment we use to monitor their vital signs. They have an emergency response bracelet. So we try to explain all of this up front so they feel comfortable with what they're getting into, but that is a risk. Also, not everyone's hot on people coming into their home, so they have to be comfortable with that. So if you can explain it well, then people have that informed decision that they can make. We've created a patient video so that patients can see exactly what it's like as well. So I don't know, AJ, do you want to take Joel's question there?
What's the question? I'm not sure I can see it.
Okay. So this obviously reduces cost. I'm wondering if you are envisioning this hospital at home program to go at full risk for MA/dual eligible populations. Mayo should get a DRG waiver for hospital at home ?
Sure. So that's a great question. I think one of the things we'd like to do is significantly increase our portfolio of risk-based contracts, whether those are managed care contracts or bundled payment arrangements like BIPSI and other ACO arrangements. What that ultimately means is that in today's world where we get paid more the more that we do for patients, in the advanced care at home model, what we'd like to do is manage the patient's care such that we pull them out of the high cost hospital, and instead we manage them using technology at a lower cost of care. And because we're coordinating their care in their inpatient and their post-acute phase, we reduce some of the readmissions and other services that are offered when you have disjointed inpatient care from outpatient care. And by coordinating care, we can lower the cost of care. And ultimately, by using different payment models, risk-based models, we can both lower the cost and share that savings with the payer and the patient. So it's not just we're becoming more profitable by lowering the cost, we're actually bringing down the cost for the health system.
I hate to intervene. However, we do have another speaker on deck that Young Hoon's going to introduce. I will say for our participants who still have questions, our speakers might be generous enough to stay after, and you could talk to them on one of the tables in Remo, or if not, you could email them directly. These are great questions. I'm thrilled. I'd like to learn more myself, but I have to progress the events of the day. So thank you both so much. This was wonderful. You can stay if you like. If you leave, we have your contact information. Thank you. Young Hoon, I leave it to you to introduce the next speaker.
Yeah, so thanks everyone for an engaging sessions of questions. That was good. So I have the pleasure of introducing our next speaker. Dr. Rajeev Chaudhury's primary interests and expertise are in the development applications of artificial intelligence and informatics solutions to support the discovery of new solutions and their applications for transformation of practice. As a consultant and associate professor of medicine in the Division of Community Internal Medicine, Department of Medicine, Digital Health Sciences, and Division of Preventative Cardiology, he has had the opportunity to develop and apply AI to use in the electronic medical record. In addition to having a clinical practice in general internal medicine, Dr. Chaudhury has had several Mayo Clinic institutional leadership roles, including being Associate Chair of Artificial Intelligence and Informatics of the Department of Medicine and Deputy Director for the Practice Current Center for Practice Transformation. He led the Mayo Clinic institutional initiatives, including the first population management IT system for breast cancer screening and the development of the web-based electronic management system for clinical decision support, and parenthetic quotes, generic disease, for preventative services and chronic disease that was operational in clinic practice from 2007 to 2017. He is an active member of the Primary Care Informatics and Consumer Informatics work groups of the American Medical Informatics Association. So with that, I'll leave it to Dr. Chaudhury to deliver his talk. Dr. Chaudhury, if you can see your cam on, mic on at the bottom toolbar, feel free to toggle those off.
He should be coming.
Okay, perfect. I'll leave it to you. Thank you.
Great. Can you see my screen?
We can see your screen. We can see it, Dr. Chaudhury.
Oh, great. Thank you. So I really appreciate this opportunity to talk to all the innovators. And I'm new to the region and also learning from Dr. Paulson and colleagues about the advanced care at home, which is a truly transformative way of providing care. So as I was thinking about what to share to ignite some interest of the attendees of what can be done, I put this presentation for your consideration. So what I'll do is I'll just go over some examples of where digital health technologies might be and where some opportunities might be. Because as a clinical informatician, my work and expertise is in connecting the technology with practice. So understanding the practice need and trying to fulfill that with technology solutions. A lot of times those are software solutions, but more and more we are seeing that the digital assets can be of extreme help. So I'll just go over some digital assets first, just to provoke your interest. So this is TytoCare. I don't know if any of you are old enough to have kids, but the kids who go to daycare get sick. And then if they start crying at 1 o'clock, the parents have to take them to the emergency room. And that's costly. You have to wait in the line there for 3-4 hours. So this Israeli company has developed these peripherals. The first one that you see on the left side can allow the user, in this case the dad, to get the auscultation of the heart and also get recorded, auscultation of the lungs and heart. There is a device, peripheral, that attaches, and it guides you to properly position in the auditory canal or the ear canal so that you can get a picture of tympanic membrane, because a lot of times these kids have ear infection and also same with throat. Now the beauty is this is available at Best Buy, $299, and I think during Thanksgiving and other times it's even lower than that, like $199. A lot of insurance companies have started now getting these to their insured, because they're realizing it's cheaper to give them to the patients rather than have them go to the emergency room. Now this is another one. It's called AliveCore. It's a small peripheral that you are seeing here. It fits to the back of, you can fit it to the back of your iPhone, or you can put it someplace, put 2 fingers on each side, and you can get your EKG recording. Not only EKG recording, it can tell you if you have atrial fibrillation, which is quite common, especially as people get old, or the young ones who go partying on a Friday night and have too much fun drinking beer. So, but it can be life-threatening because it can lead to stroke. So it's available for $89 at Amazon. The other beauty is you can load that tracing to your iPhone and you can send it to your provider. So imagine if you were having some, or a patient was having the heart palpitations or some other symptom, they'll have to call the clinic to get an appointment. By that time, their palpitations might be gone. And I'm sure that visit and EKG in the clinic is going to be much more than $89. Now here, you can do it anytime you want from your home when your symptoms arise, and get not only a tracing, but a reading and a report. For some of you who might be in healthcare, you might be familiar with this device. It's called stethoscope. Now, I'm old enough to know that I have been using this for about 40 years, but it had never changed. The same earpiece and the same tube and the same chest piece, till someone came, company called EKO, Echo, and they developed what you see in the next to the chest piece, a device. So it can digitally record the heart sounds. Of course, also the EKG, and you can again record it, send it, and someone can listen at a distance and know what kind of auscultatory finding or the findings in the lungs or the heart might be. This is another one. I'm sure some of you might have had opportunities where you get wax in the ear and you have to make an appointment to get it cleaned. Now this one is available for $45.99, has a peripheral and also an iPhone app or a smartphone app, which guides you not only as you put the tip in the ear, but also how to clean it, because it has, as you can see, some other peripherals. Margaret was showing you pulse ox to monitor oxygen level in the blood. It's available now for $16.99. I remember when I was doing my residency training decades ago, the only way we would know someone's oxygen level was we used to stick a needle in their artery in the wrist to get a sample, and then it used to be processed in the lab to measure the oxygen level and the saturation, till some engineers found a way to check the oxygen level from the skin. Actually, I got to work with that inventor because he then decided to go into medicine and was a resident at our clinic. But look at how much it has changed. You don't need the stick into the artery, which could cause a lot of complications, no wait time, um, no need to be in the hospital. You can be at home and get your pulse and oxygen level. Now, this is the blood pressure reading machine. Goes on your wrist, $27.99. Weighing scale connected to your phone. And this one, $19.98, but gives you some many other things too, like BMI and protein and muscle mass and all other things. Again, you can download to an iPhone and get those readings. Now, why all these things are important? A lot of patients that are being cared at home have heart failure. And one way to know how their things are going is by weight. So we tell them to check their weight every day. Sometimes they do that, even though it takes like few seconds. Sometimes they don't. So just for fun's sake, I would share that the Japanese, which have much more older population than we do as a percent of total population, actually developed a toilet seat. So you sit on the toilet seat in the morning and it can tell what the weight is. It can be transmitted. So these are just some examples of the digital tools that are already there. They're already collecting data. They're already passing the data to smartphones, which can be pushed on to other places, including hopefully a record system or a middle system, middleware I would call, where the data can be analyzed. Because what's happening is right now, even though we might have these assets, it still requires someone to take a look at it and then make a decision. And that's where my next part of the talk is going to go, is that how can you convert data to information, to knowledge, and automate the recommendations. So I worked on this startup from Mayo starting 2006 and had the system up and running in 2007. As a primary care provider, I used to have to look in the record to see when their last colon cancer screening was, what was the finding, to come up with a recommendation of when they should have it next. Same thing for pap smear, same thing for mammogram, same thing to know if their diabetes is controlled or not and what tests they need. Same thing for cholesterol check and when it should be. Used to take me 5 to 7 minutes, and often I would have to refer to a card to see what would be the recommendation. For example, if someone had family history of colon cancer, what age they should be screened at. So that led me to this idea that the data is already there in the record. Why can't we pull the data and apply the algorithm of care electronically to create value, so I don't have to do that again and again. So this is just a visual of what the opportunities are. So the data at that time, the technology was simpler. It's much more advanced now, so it's much easier. So there is data. Healthcare is all about data. So data is in the medical records and other systems. It's either captured from the patient, like patient fills in a questionnaire, or they answer some questions when we meet with them, or we ask them about their family history, or the data is created by us, like the vital signs, like the labs, like the radiology reports, pathology reports, what diagnosis they have. So with GDMS in 2006, we were able to pull that real time using a technology that had come that time called web services. For you who are technically savvy, it's probably obsolete now, but that's how we were able to pull. And in the platform that we created, we were real time access it, analyze the data to say, okay, this is the blood pressure, because it all comes as a bit. Then we have the rules or guidelines or Mayo knowledge, and we applied that in real time to that data to create real time knowledge. And we delivered that knowledge real time back through their EMR. So one thing I would like to emphasize is that often people come up with solutions which are standalone, and then they ask the clinicians to use that. I don't know how many of you know, but the physicians um, had it with the records because it's taking half of their time going into the medical record to find the information. So they're not going to use a third system. So it's really important to be connected within the record system. And that's what I did when I worked with this initiative in 2006, went live in 2007, that we delivered the recommendation right within the record system. And that was the key to our success and exemplary results in time saved for the clinicians, their satisfaction, their ability to provide care, the improvement in care, etc. So I'll give you an example of other practice which might be more related to the theme of this innovation sprint. A lot of patients get bone marrow transplant, and after they get the transplant, they need a lot of things done. And I'll show you the screen. So on the left side, our nurses used to have, this is at Mayo Clinic, our nurses used to have a sheet like this that they would fill in by pulling the data from record or other places, and then have this sheet ready for the physician who was going to see them. So it would take them 20-30 minutes to do that. Many times they would be working on it, and the provider would be ready to see the patient, so they're waiting for the nurse to complete. So there were a lot of practice challenges. So we worked with them and said, give us all the information you need. We'll automate it so that it comes to you in one page, summary screen we called it. So on the right hand, you see a simple app that we developed, again, within the record system to help with all the information they needed. Then they said, well, we when we see the patient, we have these guidelines that are on each provider's next to their monitor, so that they can take care of it. But often there are so many other things going on with the patient that they don't get time. So what are these guidelines? At 6 months, 9 months, things have to be done. So if there are guidelines of care and the practice is using it, that blends itself very well to a software solution to automate it. So if you see on the right side, I cut the GDMS screen that providers would have, that it would show them what is needed now, what would be needed in the next 90 days, because a lot of times these people would come from far away. So they can tell them, oh, you'll be needing spirometry to check your lung function, and you can get it done in Eau Claire or Chicago, and but you make sure you get it done. And there might be some things that are needed beyond 90 days. So essentially, we run the logic of care 3 times within our system to bring the value to the providers so that they knew what was needed to be done on that day, what was going to be coming up. Now, in this case, it's next 90 days, but in some other cases, it could be next day or the next or the same evening. So I just want to get you thinking of how all this can be done. So this was the view that the providers would see. As you can see, one page with all the summary they needed to take care of that patient and the recommendations on the right side. And then they said, well, it would be nice to have a printout for the patient. So I'm not just reciting it to them, they can walk away with that. So we created a patient-facing version from the same software. Nothing changed, just we changed the text from the recommendation. So as you can see, on the left side would be the recommendations. On the right lower part is their lab values and also the previous value, because sometimes they want to compare those. So what's the future, especially as we think about advanced care at home? And I just have the greatest opportunity to work with our practice team of Dr. Paulson and Menachi from Florida, and the nursing staff and administrative staff to help them. So currently it's taking them a while to see who's the eligible patient. And they're putting that all on a, as they get more experience, they're writing it up. Who would be eligible patient, who would not be. Once that's done, it's not hard to develop that as a system so that it becomes automated. Then the next thing is, suppose the patient is in emergency room and they think it could be an eligible patient, or the patient is in the hospital and they think rest of the hospital stay could be at home. They also need to know what could be possible complications that could happen that would make them not a good case. Again, with AI, you could predict, or one can predict, if those are going to happen. So then if those are going to happen, then those patients may not be the right one. Or if they know what would be the needs next day or day after, then they're better planned to take care of that patient. So it's all about putting algorithms to use. But the other advantage I would say is that some of the devices I showed you can also be taken to the next level. Right now, they're just pulling the data and pushing it. But you could have a way to analyze the data, create the knowledge, create a feedback loop that if someone's weight is 190 today and was 190.5 yesterday, the app can tell them right then, you are doing fine, continue with the same medications. Versus if their weight went from 190 to 192, there can be a recommendation to make a change to their medication. Or if their weight went up and their lung examination also showed some crackles, which are some sounds one can hear indicating fluid, then the escalation can be directly to the nurse or the physician. So the opportunity, as I think about the future of advanced care at home, is easier way to identify patients, easier way to predict who could get complication, easier way to take the devices and integrate those with software solution so that we are not sending healthcare allied health staff to their home, every time something changes. That's expensive when one could have some devices, and some devices are already there for this effort, but I think the opportunity is to create knowledge from the data that's collected and deliver it to the patient. So that's all I had, and I would take any questions.
Thank you, Dr. Chaudhry. The first one that I see in our main channel, have there been any reviews by medical professionals on the accuracy of...
Sorry, I can't hear you.
Oh, you can't hear me? Can the group not hear me? They can hear me, sir. Is that better? Is your audio? Dr. Chaudhry, can you hear us?
I can
great.
look at the chat and probably answer that way.
Yeah, David's
can't
question.
hear
Have there been any
anything for some
reviews by
reason.
medical professionals on the inaccuracy or accuracy of the fingertip ECG device?
Okay.
Can you hear me?
Yeah.
Oh,
No,
great.
Thank you.
Yeah, thank you. Have you heard any reviews from medical professionals on the accuracy of the fingertip ECG device?
Yes, it's very accurate. In fact, they're taking it to the next level. So initially it was developed just to transmit the EKG, but once they got enough EKG, because AI is all about data, like Dr. Helmer says, data is our oil, but then you need to know, how to mine it, how to process it, how to deliver it. Take the same example. Initially, they got enough data of the EKGs, but then they were able to say, if this is the tracing, what does it mean? So it's become very accurate to say whether someone has atrial fibrillation or not, or some other abnormality. Now that functionality is now also in Apple Watch, but Apple Watch, tends to be more expensive.
Here's another one. Are there middleware data clearing houses that Mayo currently uses to help get this data from devices to the medical records for use?
So we have worked with one time with Apple's HealthKit platform to get blood pressure readings into our system. Those of you who you follow Apple, they're actually building a very comprehensive platform for patients to have their own record and have the ability to transmit. There is a new law that was passed by CMS, which became active this year, which mandates that if you are the patient and your record needs to be passed to Apple's HealthKit, that there is no obstacle in between. So what will happen? The data would be there in Apple's HealthKit platform. People can then develop apps on it. So that's going to be a huge game changer for digital health.
Perhaps two more before we move to the next thing, and then David, again, how do cardiologists? What is their feeling about the AI interpreting the ECGs for them?
Oh, they love it. It's not a high revenue yielding procedure. Plus, it helps them improve the care to the patients. So Mayo's cardiologists actually have been involved quite a bit in this AI work and some other, because from EKG. So just give you an example. We have EKG data going back decades. We have other data like who had heart failure or who had sleep disorder like sleep apnea. So with new assets that are there for AI, you can create, you can match that. This EKG finding relates to someone's heart not being pumping right or someone having sleep apnea. So they are very active in this field and coming up with new discoveries.
That's great. And then one final one, this one, different gears. What is the current regulation around ownership of the data gathered by these wearables? Does the healthcare provider own it, the device owner, the device manufacturer, or the app manufacturer? Who?
You know, that's a very great question. And I don't think I have the answer, but I would say down the line, you could think that the patient owns it. I mean, right now, that's become an asset that the company who is collecting the data might say, we own it. But I think the rule that I mentioned is going to flatten the play field a little bit so that it's easier for the data to be exchanged with whosoever you want it to be exchanged with.